Well, good morning, everybody. I am Dr. Laura Lacher, and welcome to Medical Grand Rounds. I'm here live in Southern Auditorium at Providence St. Vincent, and welcome to all of you who are joining us on Teams Live. We'll go ahead and get started with some reminders, some logistics, and then introductions for today. Please note, next week we have a very special lectureship. It is the Lipschitz Annual Lecture, and the talk will be Dreamstorm, the story and impact of OHSU Northwest Native American Center of Excellence, and that will be given by Dr. Eric Brodt. This talk will be live, but it is only available at Providence Portland, and so that is on the Wednesday from 8 to 9 in the morning on Wednesday next week at Providence Portland. This will be a really special talk, so please make an effort to attend live. And for those of you who are here on the West Side, I highly encourage you to watch the video of that session. And along those lines, a few logistics. Grand Rounds is now a joint effort between Providence St. Vincent Medical Center and Providence Portland. We are often available live, which is typically Tuesdays from 8 to 9 a.m. here at Providence St. Vincent. And you can always join our live virtual audience. You can earn CME credit by being here in person, by watching virtual live, or by watching a recording of the event, which is available as the same link as the invite. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or any questions that you have. We may take some pauses during the talk today to field those questions, and then also at the end as time remains. And now for introductions. I'm delighted to be joined today by Dr. Clifford Ma, a board-certified, highly skilled podiatry surgeon with experience treating a wide range of foot and ankle conditions. Dr. Ma earned his Doctor of Podiatric Medicine from California College of Podiatric Medicine in San Francisco, California, and completed his 3-year residency in trauma and reconstructive surgery of the foot and ankle at Northlake Medical Center in Tucker, Georgia. Dr. Ma is the Chief of Podiatric Medicine and Surgery here at Providence St. Vincent Medical Center. He's an attending teacher for the Legacy Kaiser Portland Hospital's Podiatric Surgical Residency Program. He served on the Oregon Medical Board, is a faculty member of the Podiatry Institute, and the scientific chairman of the Oregon Podiatric Medical Association. Dr. Ma truly enjoys teaching, particularly educating residents. He continues to provide numerous lectures for continuing medical education to keep all of us up to date on these common conditions we encounter. So thank you, Dr. Ma, so much for joining today.
All right, thanks for having me. It's great to see it's kind of back and familiar faces. All right, so I talked about, when I got this lecture talk, I was like, grand rounds. I'm like, there's nothing really grand about podiatry, it's just foot and ankle stuff. So I kind of have a potpourri starting from the toes all the way down to the ankle, and I kind of broke it up into sections. So if you have any questions, comments, come on in, chime on in, and try to make it as casual and keep you awake during at 8 o'clock. So thanks for listening. All right, so as a podiatrist in Oregon, we can do anything from Achilles ruptures all the way down to ankle fractures, to bunions, and then diabetic foot. So it's kind of potpourri of everything that we can do from just the knee down. Can't go to the knee, but just right below it. The fun fact of all is 75% of Americans will experience some type of foot and ankle pain. I would say majority, you can raise your hand who's above 30 years old. Yeah, so just like, lower back, upper cervical neck, it sucks because once you turn 30, little things start to creep up. So I hope to give you those that are 28 and 27 some ideas to prevent. So when you do turn the ripe age of 30, you'll be like, all right, I'm prepared for this. So I didn't know that until I turned 30. I was like, man, this is terrible. All righty, so common foot and ankle ailments, like I said, to start from the left, ingrown toenails, hammer toes, neuroma. These are common things you'll see in your clinic, especially for primary care doctors. You'll see probably like at least 1 or 2 a day. As summer rolls around, you become more active inherently, you'll see even more of these. So ingrown toenail, if you wear a sandal, this is kind of the typical, I think, in urgent care, is you probably see 10 of these a day. Red hot, swollen. A lot of the times, unfortunately, the ingrown toenails are genetic. So they'll come in and you'll have their father or the mother be like, all right, sit down, get this done, because, I had this done when I was your age. It's like the color of your hair, color of your eyes, ingrown toenails, the shape of it is the same. The good thing about it, the procedure that's done, I'll go over it in a second, is it hasn't changed since like the late 80s. It's one of the few procedures that, if you go around the country, it's going to be about 90% of the same technique. So it's one of the few things that it works. And if you go to someone that does a little bit different, yeah, I'll show you the phenol or the cauterization that's probably pretty popular throughout the country. So ingrown toenails, the normal on the left is kind of flat, and you can see on the right it's kind of curved here. I got a mouse here, I'll show you. So the curvatures here and here on the side. Unfortunately, it hurts on the side here. Tell you if it hurts on the medial lateral, it's about the same, I would say. It depends on the type of sports you play. The tighter the shoe, unfortunately, like, soccer shoes will be more uncomfortable because they're tighter. Rock climbing shoes, that's another one that, kind of gets you. Ingrown toenails, paronychia, most common dish is, the great toe, just because it's the largest toe. It's the one that hits the end of the shoe, the most common. Prevention-wise, generally you can just trim straight across. I think the more importantly, it's a proper fitting shoe, something a little bit wider so it doesn't, rub or compress on the sides. Just be careful on the pedicure. I wouldn't pull too much skin on the side. That can cause, an irritation to the skin. The mild ones, so something like this, where it's a little bit, painful, somebody tells you it kind of feels a little funny, a little red, minimal drainage. Most of the time you can get away with treatments as oral antibiotics. I generally use Keflex for 500 milligrams 4 times a day for 5 days. Soaks, that's probably the most important. You soak it a couple times a day for 10 minutes. If you want to use Epsom salt, that's great, but just warm water to just allow this to irrigate out. To breathe the nail, I wouldn't cut too much, but some people will cut the edge here to take that pressure away. And follow up with the primary podiatrist in the week. If it gets worse, there is a nail procedure that you can do to remove part of that nail. Severe, so something like this, where it's really bad, oral antibiotics, and then, I recommend removing part of the toenail. So do you use part of it or the whole entire toenail? If it's, one side and it's not too bad, you can get away with a procedure to remove just the corner, just like this, about 2-3 millimeters. If it's both sides, pretty swollen, I recommend remove the entire toenail itself. Let's take a look. So the procedure itself, techniques, pretty much you do a digital block. So when you numb up your toe, I use about 3 to 6 cc's lidocaine, mardocaine on the proximal end, and then I use about 2-3 millimeters just take the side. For the younger patients, usually around 18 and under, won't do the permanent procedure. I'll just say, hey, this is bad luck. Let's see what happens. For patients that come in and say, hey, this is my 5th time having this, I would encourage to do the permanent. And what that includes is removing the side. You put a liquid, most popular, it's called phenol. It's a low-level chemical burn. It just cauterizes it, so it seals it, so this section of the nail doesn't grow back. It's about a 98% success. So at 2%, it can grow back. It's rare, but it can. If you do the procedure where you just remove the nail and just take the pressure away, that piece of nail will grow back. Generally, on rule of thumb, I tell patients 6 to 8 months for the nail to grow back. So if you take the entire toenail off, you just give them an idea. Hey, 6 to 8 months to grow back, and it'll take its time. Here's the entire toenail. This one here is, inflamed. You can take the whole toenail here, and, I'll tell the patients there's no exposed bone, there's no tendon sticking out. You just remove the nail. You don't need the nail anymore. It's not a lot of people that are playing sports, for the aftercare. You just have to soak it once a day and put a Band-Aid, just so it doesn't irritate the new baby skin. But you can play soccer, football, basketball, do whatever you want the next day. It'll irritate you a little bit, but majority of the time, it'll hurt so much less than they had before that they're like, hey, this is great. I can still play. So probably the one thing you probably don't want to do is like jacuzzis or hot tubs for a few days, because that's probably the most bacteria count. But other than that, you can do whatever you want. Post-op management for these procedures, daily soaks, about 10 minutes a day. You can put Silvadene, betadine on it just to, keep the skin protected. The drainage from the permanent procedure can last for a few weeks. It's normal. It is a chemical burn. So it takes about 2 to 3 weeks to seal, or for that, 1st-degree burn to seal up. But you can play sports during the entire time. Generally, the procedure is done in the clinic. Probably the cutoff, it's around 12, 13-year-old. If it's younger, say 10 and under, like ear tubes for ENT, I'll take them to the surgery center. You gas them, do the procedure, and wake them up. But usually around 10, I would, encourage oral antibiotics, soak it for a couple times a day, and see if they can wait older so they can do it in the clinic. It's just a lot safer, much less expensive. But occasionally you get the ones at 8, they've had it 10 times, chronically infected. Then I would say, hey, we can just go to the surgery center and get it done. All right, so the next thing on the toes is hammer toes, painful corns and calluses. So there's pretty much two types of hammer toes. There's rigid and there's flexibles. Here's the ones you can see, and generally as a younger patient, say, mid 40s and 50s, you start developing these curvature of the toes. And what they'll notice here sometimes is that the skin becomes dark just from rubbing from the shoes. Unfortunately, most of the foot deformities, whether it be toes or, middle of the foot, a lot of it is genetic. So hammer toes majority is genetic. So if I have someone who comes, younger, 30s or 40s, they'll ask me, hey, I'm starting to develop these curvatures. I'll generally ask, hey, next time you see grandma or aunt, uncles that are around 60, 70, just look at their toes and see what they're going to look like. You have the potential, not to say that you will, but occasionally you get the phone call a couple days later, hey, oh my goodness, grandma's looks like this. This is horrible. What am I going to do? So it happens sometimes. As they progress, you can see on your right, the hammer toes can curl up higher and they start to flow in the toes. It's like a slinky. It starts to curl up. And then as you progress in age, this can happen. I think everybody here, had a grandparent that said, oh man, those toes are crooked. So this can occur as you mature in age. So the hammer toes, conservative treatment, there's a lot of different things out there, padding, wider shoes. I think that's probably the most key is the wider shoes. And then over-the-counter orthotics is to distribute the weight better. The other item that's not on here I use is called correct toes. There's all these toe spacers. It kind of looks like the one on the bottom right here. You'll kind of straighten the toes and give some of the flexibility to make them straighter. When it comes to surgical treatment, if patients come in and say, hey, this really hurts. So when it comes, and I have some slides at the end, but when I decide to do surgery on these patients with these hammer toes, I only fix it if it hurts. If it doesn't hurt, no matter how crooked it is, how upside down, sideways, if it's accommodated with a shoe, I say just live with it. But it affects your daily life. You can't go to the mailbox, grocery store. If it hurts, I just get it done. There's two sections to it. There's a soft tissue release, and then there's a bone stiffening of it, depending on the degree of arthritis in the joints itself, or some type of combination, depending on the contracture. So here's just a classic one that we'll all see in our clinic. They'll come in, it's just a lump right on the top. And then what happens is, here's the lateral for an x-ray here. You'll have a corresponding, sometimes a callus on the bottom, and it's because of the hammer toe. So what happens is the toe contracts, the toe goes up this way and actually puts weight down. So you get like a diffuse callus, or sometimes a little spot, pinpoint painful callus that you got to remove. Some patients come in and say, hey, can you just remove this callus? I'll just wear a shoe and make sure I take some of the pressure off it. There's a lot of new shoes out there. Most popular out there is the Hoka ones that kind of look like a rocker bottom. You also have like Asics Nimbus or New Balance More. Those are just a rocker bottom where it takes some of the pressure off this bottom of the metatarsals. So the surgical procedure itself, it's outpatient, usually surgery center or hospital, but most of the time surgery center. IV sedation is just fine. You don't need general for this. This is the classic technique where it's a linear incision right down the middle of the toe. You remove the bump, so some of the toes are just stiff, and it's an arthritic joint right in the center of the proximal interphalangeal joint, or the middle of the toe here. And what you do is you open up, you take some of the bone out because the bone is arthritic. You make it straight and you put a pin out straight like this. And the pin goes right down the middle of the bone and it holds there. Generally, it's held there for about 4 to 6 weeks. The care of these pins, just like earrings or piercings, you just have to keep it clean. And then pull out or remove them in office about 4 to 6 weeks. No anesthetic is needed. You just kind of 1, 2, 3 and pull it out. I think for those that have earrings, it's like the first time to remove it. It's a little stuck a little bit, but it's literally 1, 2, 3 and it just comes right out. Hammer toes as they progress. Here's some befores and afters. Here's one here. This patient here had pain on the bottom here all the time on the ball. Basically pin down the middle and then you kind of make it straight and kind of matches all the other toes. Other thing to consider here, moving on with the toes, is lenticular metatarsalgia. So basically pain on the ball of the foot. This is probably pretty common in the summertime. Some things you'll see is capsulitis or inflammation of the joints here of the knuckles. Sometimes, unfortunately, as you mature in age, the fat pad will kind of decrease in, I guess, fluffiness, you could say, or the cushion. So your knuckles become more prominent. Very common in People that wear, hard boots for a long time, high heel shoes, puts a lot of stress on that fat pad, so it gets matted down over time. And then the two most popular I kind of focus on are stress fractures and neuroma. And I'll go over how you differentiate between the two. So capsulitis itself, inflammation of the capsule, you have pain with the range of motion of the joint itself, and you'll have some mild swelling. You can see right here on the right, it's a little puffy here. Most of the time it just goes away. Anti-inflammatories, supportive shoes, so try to avoid barefoot around the house for 3 or 4 weeks. If you need something, say the fat pad has really been matted down, you can wear orthotics. The most popular out there is Superfeet, you can wear those. Cortisone injection, I'd be hesitant to do it if you see the fat pad is kind of fading away, but if it's really uncomfortable, occasionally I'll do a real light dose. All right, when it goes to the swelling, if it's still swollen on the top and they have pain increase with weight bearing or exercise. So this is a classic where you got to get that cloud, and this is in any bone of the body where you get a stress fracture, it starts with the cloud. But most of the time, you'll come to see you at 3 or 4 weeks after, hey, my foot starts to hurt more, or my ankle, because you can get this in the ankle. You'll get an x-ray that's normal. This is something you'll see 6-8 months down the road as it consolidates. But usually to tell you it's swollen, especially at the middle of the end of the day, and it feels worse at the end. And the reason why is when you're sleeping, you're not moving too much. So the bone starts to solidify, and then when you wake up, start increase your activities, the bone starts to move a little bit and become more uncomfortable. Generally, plain film x-rays. I think the word stress fracture is tough, especially for the general community. Sometimes I always catch myself, I usually sometimes call it a stress reaction. The reason why, if it's stress fracture, but you get the x-ray report and everybody has, all their documents on the phone, they're like, hey, look, the radiologist said there's no fracture. Why do you call it a stress fracture? So sometimes I'll try to use both words of a stress reaction, where I'll give the example of when you're in like 4th grade, you take a pencil, you kind of break it, but don't break it all the way, but it's a little loose. That's what a stress fracture is, where some of the wood fibers in your pencil is a little loose. So you just know you got to be careful. For occasionally, if you get somebody that's had this for 4 or 5 months, you can get an MRI. What it is so the x-rays are normal. You get an MRI, you'll have swelling in the middle of the bone. Treatment's still the same. You still got to just stay off of it. Take it easy. So the most common bones is the red one here, the 2 and 3. The next most common bones are 3 and 4, and then the last is the number 1. And the reason why it's the most common in 2 or 3 of these are 2 of the longest bones. So the lever arm pushes more pressure on it. The areas you'll get for stress fracture for the foot itself are kind of right in these areas right here. So just like the example of the pencil, that's kind of where it bends right in the center here. Most of the time, it's especially in the summertime, they'll say, hey, I just started exercising more and my foot just started hurting. What happened? I didn't do anything wrong. I lean towards stress fracture, take 3 or 4 weeks off, maybe swim more. I'd be hesitant to do like hiking for 4 weeks. Just like I said, take it easy, and generally 90% of the time it heals on its own. Treatment size, if it hurts really bad, so say if they come in, they're limping and x-rays are normal and you suspect a stress fracture, you get one of these fracture boots. It's a stiff boot on the bottom, doesn't bend too much, takes the pressure away. If patients come in and say, hey, I got a bad hip and I got to wear something different, that I can't wear this boot, it's too heavy, just a stiff shoe. So a stiff hiking shoe would be helpful. And then decreased activities for about 4 weeks. So on average, 4 to 6 weeks to heal. You can still get around. I just, in the summertime, I wouldn't hike 10 miles a day. I would, lower it off or change the biking or swimming. That will help it kind of just relax and heal on its own. When it comes to neuroma, it's a sharp shooting pain. Usually the most common is between the 3rd and 4th toes in this area here. The biggest difference between a neuroma and the stress fracture, though, is the bone will swell. Neuromas will rarely swell, and that's kind of differentiate. Where you look at it, going, it's the same spot, because as you can see, it's right next to that 2nd, 3rd metatarsal where you can get a stress fracture. So if the patient comes in and says, hey, it hurts more at the end of the day and it's swollen more, I kind of lean towards more stress fracture. If they say, hey, this hurts all the time, or it's sharp shooting, kind of numb feeling, sometimes I ask them, does it feel like hitting your funny bone really bad and it kind of feels weird? Then you kind of lean towards more neuroma. Generally no history of trauma, activity related, so dance more, fencing, anything that's tennis, pickleball, that require more pressure on the ball of your foot or the tiptoes to move. Generally no history of trauma, just start hurting. The thing about neuromas, they'll come and go. You'll have some good days, good weeks, bad weeks, just come get you. And there's no rhyme or reason. Unfortunately, this is one of those where 30 and above years old, you'll probably get one someday. I have one, comes and goes. I do explain to them these nerve things is purely for sensory. So your toes and your ankle, your foot will still move. It just feels bad. And a degree of badness is all over the place. So I have some patients, when you get the treatment here, it's like, can I just live with it? The answer is yes. You know, this is purely sensory. You know, your toes are not going to fall off. You're not going to move your ankle anymore. No, this is purely for touch. All right, and then the most common is the third digit, but you can get into fourth. Kind of the order it goes is that between the third and fourth digit is one, and then between the second and third, and then the fourth and fifth toes. It's very rare, maybe like 5% that goes between 1 and 2. But in theory, it can happen. Shoes, gears could be an issue here too, because what happens is it compresses the bones in between, so it compresses the nerve itself. So the tighter the shoes, you know, you may want it to let it rest, just wear open toe shoes or something wider. The most popular out now is Ultra. It's a little bit wider, take the pressure off the nerve. Conservative treatments, anti-inflammatory supportive shoes. If it's really bad, I'll do a cortisone injection to try to shrink the nerve. That's something to consider. But most of the time, you know, the anti-inflammatories and the change of shoes does the trick. Occasionally, maybe 5%, you'll do surgery. You have to take the nerve out. This is one of the few things in the entire body that surgery, you know, if it's for the lower back, for nerve, you don't take any nerves out. Usually you just try to, you know, open it up or take some of the pressure away. But in the foot, for this condition, one of the treatments is taking the nerve out. It doesn't happen very often because, like I said, most of the time conservatively, it does just fine. But this is what it looks like. Oops. You know, here approximately here, the nerve is nice and smooth, and it just comes quite swollen right in the bottom. So it feels like they're walking like a marble. All right, so when it comes to the toes, any questions, comments? All right, so we'll move on to the next section is the big toe. So these are the three things you'll probably see in your clinic. You know, you have kind of boil it down to three things: bunion, gout, arthritis, or some type of combination of all three. All right, so when it comes to bunion, this popular question is acquired or congenital? I would tell majority of the patients is, you know, congenital. It's just like hammer toes. It comes from your family. And, you know, mom, dad, grandma, somebody probably has a bunion somewhere. Because the reason why is, you know, if they, when you're born, you know, at 11 or, you know, 5 or 6, it's rarely to see bunion forming at that age. You just kind of develop it over time, and it kind of leans over. So your ligaments kind of loosen a little bit, so the toe starts to drift here. A little bit, this book says about 60% female, 40% male, but I probably see 50-50. And then shoe gear, you know, there are some studies look at islanders that wear sandals or barefoot all the time. I'm kind of in between if it's shoe gear causes the bunion itself, because the one that study that shows islanders, those people still get bunions too. So I think it's more just, you know, genetic. It happens. Conservative treatment, bunion splints, wider shoes, orthotics, correct toes, these toe spacers, all of them work, you know, okay, just to take the pressure away. I think the one to choose more, probably the easiest, just a wider shoe. When you try on your shoes, I tell patients, try the middle. At the end of the day, your foot will swell about a quarter size bigger. It's totally normal. There are a lot of different shoes out there that have different widths. I do have a list that I can email to you that I use. A lot of the shoe companies, most popular, like Portland Running Company, Foot Traffic, those are two more. But even REI has their own, you know, has widths that you can go try on the shoes. The next question I'll get here is when you send to an orthopedist or podiatrist to do these type of bunion surgery, you know, how to determine when it comes to like how big or how significant the bunion is for if they get it fixed, because some patients will get one type of bunion surgery and say, hey, you can walk on it immediately. And the other one says, hey, how come my bunion, I had to be in a cast for 4 to 6 weeks? And what I'll tell you is basically the difference on an AP view, on a top to bottom view for an x-ray, it's the difference between the first metatarsal, this knuckle, and this knuckle. When these two knuckles, so you can see in these second, third, and fourth, and fifth toes here, see how they kind of bunch up together? The farther distance between this knuckle it is, the more chance, higher probability you'll need a cast, because you'll need some type of angle to bring this knuckle closer to this knuckle. If it's a mild to moderate bunion, I'll go back, and the distance is not as far, you can get away with the procedure where you can immediately walk on it. And that's how you get differentiated, where some of your patients will say, hey, how come that person got a cast, but the other person didn't? it was a bunion on both conditions. It's because on the x-ray, the distance here was different. So in the smaller one, lesser metatarsal mobility or stable in the back over here. On the mild, what they call lesser IM angle, where it's about 14 degrees or lower. Here's some pictures here. You can get away with what they call a chevron. This is a traditional one. There are some new procedures out there, minimal invasive ones, but the bottom line is it takes this metatarsal head here closer, it makes it closer to this knuckle here. So I'll tell patients here, your goal is to make these, try to get these spaces equal all the way out. So once again, if it's not that bad from this distance to this distance, you can get away with the procedure where this metatarsal head, you just move it over closer. Takes about 4 to 6 weeks to heal. There's different fixation you can use, pins, screws, it all works the same. You just got to let it heal. This procedure in a walking fracture boot or a walking stiff shoe for about 4 to 6 weeks, and then back to activities. Full activities, you're looking at about 3 to 4 months. Postoperative here, 4 to 6 weeks to heal. Some of the risks, like any infection, risk infection, delay healing of skin and bone. It's pretty rare, but it can happen. The complex one, so the larger the bunion, the bigger, the more chances you need a cast. So what you'll do is, you can see here versus the one I just showed you, the distance between here and here is almost 3 times as far. So as this becomes farther away from this knuckle, so once again, see how these are all kind of bunched together. Your goal is to make this knuckle closer to this knuckle here. And to do that, majority of the time, you have to do a procedure, something back here to swing this over. So just kind of just like geometry, you got to do something angle back here to get it over. Occasionally, there are some MIS or minimal invasive surgeries that you can move this over all the way, but that's kind of pretty rare. I think if you're of a middle-aged 40 to 50-year-old, they'll tend to lean towards this procedure to straighten this out. So what this looks like this, where you can see it's straight here. You can cut a wedge in here, you can put a pin or ostick joint, but the bottom line is you want this knuckle here back closer to this one. So you can see the before and after, probably like half the angle is gone. When you're in the cast, you're about 6 weeks to heal, 5 to 6 weeks in a cast, 4 weeks in a walking boot, and then physical therapy. So when you're in a cast, the recovery is probably almost twice as long, just because you'll start to get muscle atrophy because you're in the cast. I will, for both bunion procedures, the front of the foot or the back, I will send you the physical therapy. But the one that's in the cast, it's a little bit, probably a month or two longer to kind of get the giddy up back to running or walking. Both these patients, procedures are done outpatient, IV sedation. So just like the anesthesia where you have for your colonoscopy, takes about, on average, about an hour, hour and a half. That's it. And then the next thing for the bunion is hallux limitus, or a dorsal bunion. What it is the bump on the top. So there's 2 bumps you can see, and I'll go back. There's one on the side where it's over here. That's the traditional bunion cone here. And then the dorsal bunion, which is the top, unfortunately, it's more arthritis. So what you'll see how it presents, it's a lump right on the top here. And what that looks like is you get an x-ray on the side, there's this little hook right on the top over here. Some patients will tell you, hey, it's stiff, especially when I run uphill, my toe doesn't move as well. I feel a bump, especially on the top of my shoe, or it hurts when I move my toe up and down. This is a progressive, very common in people that play a lot of sports when they're younger. It is like knee arthritis, hip arthritis. It is a overuse or high activity patient. They'll know, generally they'll tell you, hey, I remember I had this around 35, 40. I just knew something was kind of goofy. And then now I'm 55, 60. This bump's got a little bit bigger. It's more painful. Very classic for any type of arthritis in the body. And that's kind of what here. This one's pretty self-explanatory. You show them this picture, they'll be like, all right, that's a hook there. There's no like and, ifs, or but. They can see it very clearly. Same as for the regular bunion, for a dorsal bunion, anti-inflammatories, steroid case injections, padding, wider shoes. Once again, this is arthritis, so it's very similar to people that treat it for knees and hips. So same concept, cortisone injection, kind of bracing it, and you can get a cortisone injection every 3 to 4 months just to get you by. But the first injection, I'll tell you, patients, it's the best you'll ever have, and unfortunately, as you mature in age, it will lessen because your cartilage is eroded over time. Treatment, so you fail treatment, it hurts. There's 2 types of kind of section depending on the degree of arthritis, also depending on age. There's joint sparing, where you kind of clean up the joint. So these are procedures just to clean up the joint, allow the joint to move more, but you don't have that big hook on the top. And then something more destructive where you stiffen the joint or put an implant, kind of like the knee, where you kind of scope it first, and if it doesn't work out, you can replace it or get that done as you mature. Gout, that's kind of another one here. A lot of the summertime, especially in July 4th, we drink a little more alcohol. Red hot swollen joint, elevated uric acids. I probably see that 50% of the time, just because by the time they see you, they probably have that uric acid starting to go down. But I do tell patients, if it happens quite a bit, it is a destructive process for all your joints. And that's kind of what I emphasize it. Like if you get it 1 or 2 times, it's not a big deal. But if you get like 5, 6, 3 or 4 times a year, your joints will erode. The cartilage in your joints, not just your toe joint, but all your joints will start to get stiffer over time. When it's really bad, it's gone. I mean, if you look at the x-ray and they have gout, it'll be fully dissolved. That's kind of that sign you see called a Martellus sign, where the kind of eats away at the bone there. But the gout itself, when you get it early, I would say around 30, 35, you'll start noticing, they'll have a party, red meats, red wines, shellfish, probably the top 3 that we've all learned in school that, hey, this is what's going to potentially cause gout. Biggest thing is to treat it is I put kind of lukewarm water, not cold water. And the reason why is if it's inflamed, it's back to like the 5th grade science where you take cold water, you put salt in it, it will crystallize it. But when you warm up the water, the crystal dissolves. The same principle here. So if it's a gout attack, I'll say just put lukewarm water. It'll kind of soften the crystals. This is what it looks like. It's just kind of chalky material. If you have to take it out, if it's uncomfortable. Gout treatment, anti-inflammatories, if they're on the phone and I can't call in a prescription, I'll tell them to take 2 Aleve twice a day. That'd be helpful. Occasionally, if it's really bad, steroid injections, warm soaks once again, and then diet. Fortunately, with that into Google, I mean, there's a lot of stuff out there about, gout diet, and I'm all for it because, unfortunately, the only medication right now that's consistent that I've seen is this allopurinol. But once you take it, you got to take it forever because if you stop, you'll get gout attacks, quite often. But the diet is probably the number one. And then drinking water, 32 ounces once a day. That's the general rule of thumb that I've learned. That'll kind of just wash out the uric acid. For those that drink wine, if you had to pick one, unfortunately, you have to pick the white one if you don't like white too much, but that's less purines in it. So that's why I have a red and white. Or you can just drink both and just half the red and drink a little more of the white. But the bottom line is for the alcohol itself, yes, the red wine is purine, but if you just drink like beer, for example, it's not the alcohol, it's a dehydration. So you're dehydrating yourself, so your chemistry in your body, your uric acid, is going up because you're going to the bathroom more. So, alcohol, they'll be like, oh, I'll just drink, a whole bottle of Chardonnay rather than just, half a bottle of Pinot Noir. But I'm like, no. It's still bad if you drink a lot of alcohol because you're going to just urinate more and then your uric acid's going to go up. All right, and I show this picture this is the person that had it really bad. So this is like a mid-60, had gout all his life, but this is what it looks like. So it just basically eats away the cartilage and just kind of chews it up. It's quite amazing. But on the x-ray, what you'll see is it's not that bad. And I apologize, I don't have this, I haven't put an x-ray on this. You'll get the x-rays and it's actually in the hip and knee too, where you're like, oh, it's not that bad. And then you actually do the surgery going there because the toe doesn't move well, and then the cartilage is totally gone. And the reason why is the cartilage is erosion, but the bone underneath called the subcondylar plate, it's still there. So it makes it look like your joint is okay, but in reality, when you go in surgically, it's completely gone. And I believe it happens in the hip and the knee too. All right, any questions on the big toe? I had 2 kids back then. I have 2 more that are bigger. Right. All right, so the next thing coming up is ganglion. Oh, right.
Going back to the bunions and the treatment, you were stressing that the more proximal joint needs to be affected. Okay, but that x-ray looks great. But the distal joint, what have you done to that to make it straight?
Oh, to bring it straight? Oh, it's a good question. So over here, you actually do a soft tissue. So you release the soft tissues here. So let me go back to the picture. So over here, these two things called sesamoids work like a kneecap in your big toe. There are tendons and ligaments that go this direction. You actually release this, and then you tighten this by suture here to rebalance it. So it's like a teeter-totter. You're bringing the left on this, let's see here, your left here, and you cut it, and then this allows this kind of a spring to release and fall this way, and then you put suture over here to swing this over. In addition to, as you move this bone over here, this kind of rebalances, causes a double effect. Yeah. And in treatment for hallux limitus, you know, the fusion is one thing to make it stiff. Patients that have it stiff for a long time, I just tell them you have a painful stiff joint that doesn't work, you'll get a pain-free stiff joint that doesn't work. So most of the time, patients that are active, I'll lean towards more what they call an orthodesis or a fusion of the big toe joint. Patients that say, hey, you know, I don't want to fuse, I know it does restrict your shoes. So if you want to wear a little bit of heel, then I'll do an implant. The disadvantage about the implant only lasts about 5 to 10 years. So if you're really super active, it will break down. You got to do it again. So I generally, you know, lean towards the fusion. But majority of the time patients come in, the toe is so stiff and painful. They're like, hey, this has been stiff forever. I don't know a difference. I've lived with the stiffness. You know, the cartilage is 90% gone. You know, I'm just removing the last 10% for you and making the joint smaller because I'll remove all the bone spurs. So most of the time, I'd say greater than 70–80% of the time, I will do the stiffening of the big toe joint. You can still run, you can still jog. The question I'll get is, can I still wear the shoes? What shoes can I wear? And I tell patients, whatever shoe you can wear today, you can wear the same one after the surgery. It just won't hurt. That's the biggest thing. Sometimes you'll get patients, hey, can I wear these with like a 6-inch heel? I'm like, well, can you wear it now? They say, no. I'm like, well, you can't wear it afterwards. So that's the hard one. When it comes to arthritis for any of the body, I think as technology, have you gotten better and better? Patients are living longer and longer. It's tougher because we haven't, you know, we can fly on the moon. We haven't figured out how to fix cartilage. And that's the most interesting part about it. You know, once that's gone, it's gone. So it's tough. They come in 75. I cannot believe this is happening to me. I'm like, well, your parents died, they're 50. You're 25 years ahead. You know, we don't know that. Did your cartilage last that long? So that realm right now, it's almost a daily conversation of like, yes, we have iPhones, but no, we don't have cartilage to fix it, because they kind of look at you going, can't you just fix it? I'm like, sorry, it cannot happen.
Dr. Ma, I have one online question about the big toe. What to do about a great toe that is pointing up that makes holes in the shoes?
Yeah, there's a soft tissue release. You can release the tendon surgically, but the biggest, I would recommend correct toes. You can wear them at during the day only, and it will stretch the tendon out over time. So you got to wear them every day for about 2 or 3 hours a day. I can give you the link for it. It's just toe spacer. That's definitely helpful. It will kind of stretch the top of the toes, tendons, and then kind of allow your bottom of the toes to become stronger, so it evens it out. But I can refer you to the website to get it. We also have it in our office too, but it's easier to buy it online. All right, so ganglion cysts. So ganglion cysts, like the hand or the wrist, it happens in the foot, can come from either two things, the tendon sheath or the joint capsule. Conservative treatment, like the hand, you can aspirate it or you can surgically remove it. Majority of the time, the only time that I would recommend or encourage to take it out is if it's really painful, and if it's painful because of there's a nerve that runs right over it. But most of the time, you know, I just say, hey, just live with it. Unless it's, you know, if it's next to a nerve, it's uncomfortable. Okay, we can aspirate it, but there's a 30% chance it'll grow back because you're just taking the fluid out, but the balloon is still inside. And then you got surgical treatment. You can take it out, but unfortunately, once you injure the capsule or the tendon sheath, there's about 10% coming back. So it's rare that I take these out, like the wrist. It's kind of the same treatment where they're like, hey, you can live with it, or you can take it out if it's painful. But in the foot and ankle, when it's painful, it's most of the time it's because there's a nerve running by it. All right, so next most popular thing you'll get is heel pain or plantar fasciitis. I'd say everybody after age 30 gets some form of it, mild, moderate, or man, this really hurts. Heel pain is one of those where it's interesting. Over time, I've learned is it doesn't matter if you're tall, short, super active, non-active, you know, have 6 kids, have 0 kids, triathletes, or just watch TV. Everybody get heel pain. It's not one of those where it's a certain category. And I always find interesting because you're thinking, all right, heel pain only happens to people that are not as active. No, it happens just as much almost. So traumatic, neurological, arthritic, and you know other can cause heel pain, but most of the time it's mechanical. Majority of it. That's what you'll see in your clinic. The post-static dyskinesia, there's a word for it where after you rest or first sip in the morning is uncomfortable. It's because the plantar fascia on the bottom gets tight or relaxed. You take that first step, it pulls. Improves with exercise and walking. The reason why is because the plantar fascia starts to stretch and take some of the pressure off it. The most popular or common area that hurts is right on the bottom here, right where the heel is. But you can have pain anything along the plantar fascia, because the plantar fascia is the entire bottom of the foot, kind of like the palm of your hand. You have a fascia on the bottom here. Differential diagnosis, because I'll get X-rays if they had a pain for a while. Stress fractures, nerve coalition, but these are like 5% or 2%, very rare. Most of the time, it's pain on the bottom, no trauma. I lean towards plantar fasciitis. Function of the plantar fascia supports the entire bottom of the foot. It supports the arch. So in the 80s, they used to cut these all the time for treatment. Now plantar fascia surgery is pretty rare. I think doesn't happen very often. Other thing you'll get your X-ray, and the patient will ask you, hey, I got a spur, you got to cut that out. In the 80s, they used to cut this out all the time, but there are a lot of studies now show that it's not the spur that's causing the pain. It's the plantar fascia or the ligament that connects it right here that's uncomfortable. So it's this connection, and how the bone or the bone spur occurs is because you've had this tightness of the plantar fascia for a while. So the plantar fascia pulls on the periosteum and then it ossifies. So like I said, it's rare to cut the spur out. I mean, it happens occasionally, but majority of the time, people just leave it alone and focus on the plantar fascia. Treatment, exercise therapy, probably the most popular. Physical therapy, Graston, A-stim is pretty common that I use. Just basically like a deep massage just to take away the tension. Shoe gear, Asics, New Balance, Brooks, those are pretty popular ones out there. Night splint, that's helpful. If you type on like Amazon, there's a million types of night splints. They're all different types. They all work. What a night splint is, it just keeps your ankle pointing to the sky, or basically looks like an Achilles stretch, looks like that. So basically, this is a contraption that makes this stretched out during the night. You don't have to work during the night. You can work during the day, sleeping, watching TV, eating dinner. People that work a lot at home, they can put it on when they're on their computer so they can get it stretched out. I have very few complaints of like, hey, the night splint didn't work. The complaint is it's just cumbersome. It's a pain of, you got to put it on, or people can't sleep with it on. You can do orthotics, taping, splinting, occasionally a cortisone injection, oral medication, anti-inflammatories, but I put exercise therapy. You got to move around is the most important. Majority of the time it goes away. I think 99% of the time it goes away, with these types of treatments. And then once you have it and it's gone away, you got to do, and I have it here, this, if you had one stretch, so every foot and ankle condition, this is the stretch you have to do for those. So I guess you can say at age 30, do the stretch 2 or 3 times a day. This will help a lot of the ailments here. And the reason why is as you stretch this Achilles, it takes the pressure off your plantar fascia and also takes the pressure off the ball of your foot, so you don't get those, potential stress fractures or neuroma. So the takeaway for this one is, for everybody, if you had to do one thing in the morning as you brush your teeth, because I do it, is just do this, brush your teeth, and stretch your Achilles out on both sides. Once you have plantar fasciitis and you do all the stretching and it goes away, you got to stretch forever because it'll come back. So it's not one of those where you licked it and you're done for good, will never come back. Now you got to keep stretching for a long time. Devices, here's some orthotics. There's a night splint. This is the most aggressive, but there's a lot of different types. There's smaller ones. There's one with socks. There's one with little strings. They all work. Treatment, 3 to 6 months. But really no issues. I think majority of the time you tell them and say, hey, this is what you got to do. I have a sheet on this, has all 10 things. So hey, go for it. Other treatment, PRP injection, shockwave, possible surgery. These are rare, like 1-2%, but these are options if you've had plantar fasciitis for 9 to 10 months. Posterior heel pain, you'll get a Haglund's. This is another spur on the back. What it looks like on it's called a Haglund's deformity. It hurts on the shoe in the back. This is what it looks like here. Unfortunately, besides shoe gear modification, the only way to get rid of this is surgery. Conservative treatment, you want to like stretch, do that Achilles stretch, so you take the tension off that bone spur here. But the bump itself, you either live with it or you take it off. There's like no shot to make that bone dissolve. This is just different types here. You can see where it's bone spurs. How you get it is usually just activity, where same thing, it pulls on the periosteum and be uncomfortable. First line treatment, just like plantar fasciitis, orthotics, physical therapy, occasionally oral steroids. If it's really bad, you can do a steroid injection, but it's pretty rare. I wouldn't recommend it. You can cause an Achilles rupture. But this is what it looks like if you have to do surgery. Like I said, this is pretty rare. I try not to do it. What you do is just, this is the size of the spur, you take it out. There's different type of anchors, but the bottom line is you take the spur off here and you put an anchor to reattach the Achilles. The recovery is about 4 to 6 months. You're gonna cast for a month. So I'm doing actually one tomorrow, but he did 8 months of physical therapy. So I try to, tell him, hey, don't do surgery unless you really need to. Post-op care, non-weight bearing 4 weeks, and then physical therapy. Next category for the middle of the foot is flat feet. You got flexible and rigid. For the pediatric one, majority of the time they grow out of it. You just got to wear, good shoes, wear some orthotics. Occasionally, if it's really flat and you failed all that, there are some surgeries you can do. When it comes, and I'll show you some pictures, when it comes to adult, there's one, it's a term called adult collapsing pes valgus planus. It's a flat foot. It happens around 45 and 65, usually unilateral. It's because the tendon just gets tired over time. And what that is the arch just totally collapses. And here's a picture in the back. You can kind of see how it leans. Here's medial and lateral and just puts all that pressure right on the side here. Conservative treatment for either pediatric or adult, supportive shoes, orthotics. You can do a brace, custom AFO. These are made by Podortha. It's just, it basically is an ankle brace and orthotic together. Stiffer shoe, that's helpful. Surgical planning, there's a lot of different types. I just give this here just to give you an idea of, is it flexible, is it rigid, depending on the age and activity levels. For flexible ones, for the kids, you can put little bone grafts in here to give them arch. It takes about 6 to 8 weeks to heal. Unfortunately, as you mature in age, say it's like 65, 70, you try the brace, it still hurts. You can see it's unilateral. This is straight, this one's far left. There are pins and screws to pull. This is a big procedure. I do quite a few of them, but I tell them, hey, it's a year-long recovery. It's 2 months in a cast, a couple months physical therapy. So I try to avoid this. They have to exhaust everything before I even consider doing this one here. Post-op care, 6 weeks. Arthritis, whether it comes the big toe or the ankle, orthotics, steroid injections, kind of the same thing for the knee and hip. You can get localized arthritis, osteochondral lesions in the ankle, just like the knee and hip. You can do some cool stuff, cartilage replacements through the scope. This is what I've done here. Usually my limit is around 15. That's what the book says, where it will regenerate. This is what it kind of looks like here, where you just resurface the cartilage here. Unfortunately, for others that don't want to, but juvenile cartilage is somebody actually is juvenile that passed away, that you get the cartilage to regenerate in there. Any questions so far? All right, so I'll wrap it up here. So I'll end with this, and this is a question I get all the time. I'm pretty conservative, but the question is, whether it be from a primary care doctor or for the pain associate, when should I have surgery? And I kind of boil it down to these 5 things here. It's pain, that's number one. If it doesn't hurt, no matter how big your bunion is or how bad your hammer toe, I was like, hey, just live with it. Don't worry about it. If it limits your daily activity, so if it affects your life that you want to do and you can't do it, all right, I'll consider it. Post-operative recovery, do you live on, especially in Oregon now, like I live in a tri-plane house and my bedroom's on the 3rd floor. I was like, well, you're gonna cast for 6 weeks. You're gonna have to get everything on the 1st floor because there's no way you can go up the stairs up and down every day. Family assistance, it's common. So right foot surgery, so you can't drive for a little bit, you can drive your left. And if you live alone, I mean, that's a tough one. You got to make sure you have someone to help you out for the first couple of days, especially in the cast. And expectations. I mean, if they come and say, I just want to walk pain free, I'm like, all right. But if they tell me, hey, I want to be able to run a marathon, I'm like, well, I don't think you had run a marathon for about 10 years. That's just not going to happen. So those kind of 3, but the number one is pain. If it doesn't hurt that bad, or it's comfortable and you can do your daily activities with the bracing or orthotics, I say just live with it until you can't, do those activities anymore. Shoes, I can give you the list here. I can email those stuff here, but there's so many out there, the technology out there. It's amazing that, in the 90s versus now, the type of shoes out there, the type of technology, it does change every year. I just had a shoe talk. I go to a shoe talk once a year just to see. It's like cars. You get one, you're like, oh, that's a nice Toyota Camry. And then the next year, like, what happened? It's the same Camry, but it's, the name is the same, but the shoe is completely different. Running walking shoes, New Balance, Asics, Brooks, these are Hoka ones. These are kind of the common ones that come in widths. That's it. Any questions?
Great. Thank you so much, Dr. Ma, for a lot of practical information and also some references and your contact.
Yeah, here's my cell phone. You ever need anything, just text me or you can email me. I'm happy to help. I don't mind.
All right, Dr. Ma, nice talk. Thank you. I have a question.
Yeah.
So if pain is the #1 complaint from the patients,
Mhm.
how about do you do any kind of neural ablations?
For the neuromas, it's kind of mixed reviews. I guess one category with the neuroablation I'll do a alcohol injection, a dehydrated alcohol injection for the neuroma. That's probably one, but as in like neuroablation to go in and ablate the nerve for neuroma, I have a few colleagues done it, but it's not mainstream for foot neuromas. I'll answer your question.
What about spending time barefoot? Is there any benefit to that?
Yeah, I think that, I think in the middle 90s was the Barefoot Running book. There's actually another book coming out. I think you already brought it out. I think at the beginning, you may want to just kind of slowly get into it. I'm not opposed. If you start running barefoot, though, I'd run barefoot like on a recycled track, rubber track, or on a grass field. I think the worst is, you go from not running to all of a sudden barefoot running. That's the big one where you're going to start getting injuries, or not running and go barefoot running on concrete. I would go from a gradual, I have a colleague, I just talked to him a couple weeks ago about it, where he says, all right, I do train barefoot, but he runs like 30 miles a week. So he'll do maybe like 20 miles a week, regular shoes, whatnot, and then 10, he'll split it out, 2 miles a day or something on just grass or something soft, just to keep the structure of the little muscle. So I'm not opposed to it, just within reason. I think it works great. It's just when you go extremes, that's when you get the problems.
Thank you very much for the talk. Quick question about what's new in the world of diabetic foot infections. I've seen some new covering, like the foreskin and the umbilical coverages. Are those effective? Have you had success?
Yeah, so
with
I've
those?
done quite a few of those, but I think the hard part of all is when your A1C is 9 and you can't stay off your foot no matter what I put on the bottom of your foot, it's just not going to work. So do I use that stuff? The new, umbilical cord stuff, most popular is Stravix. Yeah, I've used it, but they got to get, part of it is off the pressure, stay off of it and get your A1C, at an appropriate level. So it's life changing. I think to get a foot, now there's another talk I'll be, happy to come back because I didn't go over, but when you get a diabetic foot in your office, when it's just like a toe, unfortunately, a lot of other things have gone wrong to get to a podiatrist. It's not just a toe wound. Like when I get a toe wound, I'm like, oh man, so hey, how's your A1C? They're like, what's that? I'm like, okay. And then you're like, oh, what's your sugar levels? Like, well, I've had diabetes for about 10 years, but I haven't checked it for a while. I'm like, oh man. But in their patient's mind, it's just a toe wound. And I feel bad because to get the toe wound, I think, I'm exaggerating, but you need 10 things to go wrong in your body to get there. So then when you get to me and I'm like, oh, this is going to be a long conversation because I'm going to try to change their lifestyle. And they've had this for, say 10 years. But back to your question, have I used the new stuff? Yeah, I have. But I think those are more adjunct to do it. You got to stay off it. I think the tricky part about those new skin grafts, man, they're expensive. You're looking at not hundreds, but thousands of dollars, tens of thousands of dollars. And if you can't stay off of it, you can't control your diabetes, it just doesn't work. So I'm pretty restrictive on it. And I'll tell a patient, hey, this is what I offer you, but you got to get better. And then the kicker on it, if you're diabetic and you're a smoker, oh man, that's gonna be a long road to get anything to heal. But for patients that are, hey, I'm gonna turn around, I've seen quite a few of them where like, I got them fixed to come back. Their A1C's, 6, 5, 7. They're, exercising, eat well. They lost 100 pounds. I'm like, man, I high five. I'm like, you should be proud. I'll tell them specifically too, hey, you should be proud of yourself. This doesn't happen very often. Hold your head up high because you changed your life and you're gonna live, another 50 years longer. So I make sure I, emphasize them, hey, you did a good job.
Great, thank you. Very common and complex problem we encounter for sure. Any thoughts or tips you have for patients who have more of a chronic paronychia?
Chronic paronychia, unfortunately, is to remove part of the toenail, like I showed you, to remove that. And if you have it, 1 or 2 times, no big deal. But if you have it, 5, 10 times, removing part of the nail is the best. You know, if you look on the internet, people put like, you know, dental floss in between or cut a V in the toenail. Unfortunately, it's the shape of the toenail. There's nothing I can do to like take the nail, hammer it down, flatten it, put it back on. That curvature is there forever. Occasionally, if you take the toenail and it just gets more, you know, uncomfortable, I'll get an X-ray just to make sure there's no bone spur underneath. It's like a 1%, but it can happen. So if you have chronic paronychia, if it's really pointed, I'll get an X-ray just to make sure. But sometimes just the kind of the bad luck, the gift from your parents or something like that. But remove the toenail, ultimately, that's like the end all be all of like, hey, you have no paronychia, because no nail, no paronychia.
Great. Another question here online. Can you briefly discuss callus on diabetic feet? Under what circumstances do they require podiatry referral?
You know, once I see a callus, I would say every 3 months to remove it, because those are preventive. So in our clinics, we have a podorthus. So, and then we have a kind of a regimen. So every 3 months, Medicare will cover it, where you go in for a diabetic check. If you have neuropathy and you have a callus or a deformity, you can remove. I recommend you remove the callus every 3 months. Diabetic shoes, you qualify for 1 pair of diabetic shoes once a year, and then the orthotics, the supporter orthotics, 3 times a year. So that is a regimen that, you know, majority of the podiatrists in Portland will have that type of protocol. So the answer to your question is, once you see a callus, just send them over to podiatrist, and, you know, we'll take care of it. But rather than waiting to let it fall off, just remove it, because usually what happens, that's usually what's the start of an ulcer.
Great, thanks. That's super helpful. One last question here.
When does Medicare start covering diabetic shoes once a year? What actually has to happen? Do you actually need to get an ulcer, or?
No, yeah, usually diabetes and a deformity. Those are the 2. Yeah, if you don't do, you have to put in the note. So there are a lot of hammer toes out there. I'm not gonna. You get the gist.
I have yet to see a foot that is not deformed. Over 30.
It's like the same one you know, by the way, I've enjoyed every moment of working with the primary care doctor residents here. I do it at the Milwaukee clinic. It's great. And the biggest thing that comes to me now, this has happened like, I think 3 weeks ago. It's like the Ozempic one comes up like, oh, you need to be diabetic to get it. And I'm like, are you telling patients? I'm like, I'm not saying anything, right? We all laugh, but I'm like, oh man, this sucks. Versus getting it to prevent you, because you have that, you know, gray zone of pre-diabetic between, say, 6 and 6'5", you know that you had it, you could probably save you, but I mean, you hear it between the lines like, oh, just get the 6'6", and, you know, it's crazy.
Well, thank you, Dr. Ma, so much for teaching us and for your excellent care of our patients. Take care.
Thanks for having me.